Hi everyone. The rectus sheath hematoma is more like bleeding from injury to the deep inferior epigastric artery, which insects into the rectus abdominis muscle. So we know that the rectus abdominis muscle is one of the superficial muscles within the central part of the abdomen, right? And it is covered by an aponeurosis, right, which is called the rectus sheath. Enclosed within this muscle and the sheath is the inferior epigastric artery, so it penetrates deep into the muscle and it is contained within the muscle and the fascia, which forms the rectus sheath. Now, below the Harquet line, I know that Dr. Babainde must have talked about this. Below the Harquet line, the posterior aspect of the rectus abdominis muscle is not supported by the posterior rectus sheath, so it's not covered by that sheath. So because of the fact that it's not covered by that sheath, it's kind of predispose that vessel to like tear, so that vessel can easily tear, and that means that the bleeding will be confined to the muscle and the fascia, so that brings about the formation of the rectus sheath hematoma. Don't forget, the artery penetrating to the muscle is covered by the fascia or the sheath, so it means that if the artery tears, there's going to be bleeding within the muscle, within enclosed within the fascia too. So, and that forms the rectus sheath hematoma. And because of the fact that um, the the most vulnerable site for the tear is below the Harquet line, so you tend to see most of the rectus sheath hematoma formed at the lower inferior abdomen, right? So how would they present? So individual with rectus sheath hematomas usually present with abdominal pain. They have a palpable abdominal mass, right? They can complain of referred pain to the back, to the legs, because the hematoma can expand and compress on the thoracic, the lumbar nerves that supplies the back and the legs. So, but you need to elicit some signs to help us delineate between the source of the hematoma, if it's from the abdominal cavity or from the abdominal wall, right? Because we are dealing with rectus sheath hematoma, which is from the abdominal wall. So how are we going to be sure that what we are working with is from the abdominal wall? So the first is the Carnett sign. So Carnett sign just means that um, you are trying to demonstrate that the bleeding is confined to the rectus muscle and the rectus sheath, and you don't expect it to change, as with body movement or contraction. So what you do is that the patient lies supine initially, and you tell the patient to sit upright while lying supine. So the patient lies supine, then sits upright. So that sitting upright kind of contracts the rectus abdominis muscle, and you will have tried to palpate for the point of maximal tenderness. So once you identify that point of maximal tenderness, and you tell the patient to, move from his supine position to, sitting upright with contraction of the rectus abdominis muscle, you will still notice that that side of maximal tenderness does not change, because the hematoma is confined to the rectus abdominis muscle and the sheath. So that's where it is. It does not change. It's not within the abdominal cavity that can be dangling from one point to another. So it remains fixed. And even with, positional change, it's still constant. So it is unchanged. That confirms your rectus sheath hematoma, because the bleeding is always confined within the rectus abdominis muscle and its surrounding sheath. Then the next is the Fothergill sign. So the Fothergill sign just means that um, you tell the patient to lie supine, and you try to do some tests to also contract the abdominis muscle, such as telling the person to um, place their hands behind their head and elevate their head, or you tell them to lift their legs, to lift their lower limb. So they put their hands beneath their legs and they try to lift it up. So all these things can contract the rectus abdominis muscle. And because of the fact that the mass is confined within the muscle and the sheath, it does not move, it does not change or crosses the midline. So if it does not cross the midline, that tells you that the source is from the abdominal wall and not from the abdominal cavity, right? So and there's no movement, and the mouth does not move. The mouth doesn't move with contraction of that muscle. So that's what your phalangeal sign, you know, is suggestive of. So your phalangeal sign helps you to confirm that what you are dealing with is a rectal sheath hematoma. So phalangeal doesn't move further. So it doesn't cross the midline or it doesn't move with your positional change, like, elevating the lower limbs or elevating the head. Why can't it means that the point of maximal tenderness is constant, as you are moving from a supine position to sitting upright. So after you have done your examination, you can now confirm by doing your radiological imaging. Your CT scan is going to confirm, CT scan of the pelvis and the abdomen is going to show the hematoma, right? Because they have bleeding into the muscle. So you need to do your full blood count to measure the blood count, leukocytosis, and all those things. If there's a need for transfusion, maybe the count is less than 7 gram per DL, you need to transfuse that individual. You need to give them initial fluid resuscitation. You need to also monitor the count to see if the bleeding is stopped or is still ongoing. And you might need to evacuate. You need to evacuate the hematoma. So you can do a CT guided surgical evacuation of the hematoma. And if you can identify the vessel that is bleeding, which is that inferior, that deep inferior epicapsular vessel, you ligate the bleeding vessel, and you can place a suction so that you don't have a recurrence of the hematoma. You don't have it reaccumulating. So once you are done with your surgery, leave a drain there to help you drain any blood collection that might occur after the surgery. So that's that about rectal sheath hematoma. Then moving on to bladder injury. So bladder injury is very common in people with pelvic fracture. Um, and it depends. You classify it into two different types depending on the communication of the peritoneal cavity, the intraperitoneal and the extraperitoneal. So I have our first stage from our step 1 here, which is quite helpful um, in the classification. So we have um, the first one, which is the superior bladder wall injury or the dome injury, and the anterior bladder wall or the neck injury. So if you have injury to the upper part here, that's the superior bladder injury or the dome injury. That's the weakest part of the bladder. Or if you have any injury to anything beneath here, like the anterior wall or the trigone of the bladder, that is, the extraperitoneal injury, right? So what happens is that um, uh, for the extraperitoneal injury, it means that there's an injury to the trigone or the bladder neck, right? So that area can rupture, and there's going to be urine extravasating just behind the pubic bone. So if this tears off, right, this tears off, you are going to have urine accumulating in this space. You call this the retropubic space, right? So that doesn't communicate with the peritoneum. The peritoneum only covers the superior aspect of the bladder, so not here. So that is not going to communicate with the peritoneum, and that is not going to cause serious problems. So because the kind of defines the approach to the treatment. So if it's extraperitoneal because it's affecting the bladder, neck, the trigone, and there's bleeding into the retropubic space, what you just do is you can just pass your Foley catheter, right? That's the way you treat it. Just treat non-operative by passing your Foley catheter to just drain whatever urine is coming into the bladder, right? Most of the time you see them, they present with gross hematuria. So once you see gross hematuria, think about bladder injury, think about renal injury. So in addition to the gross hematuria, what is going to tilt our mind towards bladder injury is that they are going to have suprapubic pain. So they can have difficulty voiding, they can have suprapubic pain, and tenderness, they can have gross hematuria, right? So um, you know, and once you have delineated that, okay, this is extraperitoneal, you know, you should treat non-operatively. So one thing that the question stem is going to likely show us that we can quickly use to separate them is that because for the intraperitoneal, you're having an injury to the dome of the bladder, right? And that urine, maybe due to the fact that the person is using seat belt, the bladder is full, and the person suddenly had maybe a motor vehicle accident that transmit the pressure to the bladder dome and tears it off. You can have extravasation of urine into the peritoneum. And when urine is absorbed in the peritoneum, there's going to be elevated blood urea nitrogen level. So with that, you can have an idea of the mechanism of injury that is likely to be from the tone, because I can see elevation of the blood urea nitrogen, right? And of course, there will be evidence of peritonitis. The abdominal pain is going to be diffuse. There's going to be abdominal tenderness widespread. There's going to be rebound tenderness. There's going to be abdominal rigidity. You will not have that with extraperitoneal, right? So it's going to guide us, and urine output is going to be low or absent despite aggressive reaction, because the bladder is already torn. All the fluid is just entering in, the urine is just entering to the peritoneal cavity. So in that situation, you need to do a surgical correction. You need to do a surgical repair, because you can't allow urine, which is an irritant, to keep entering into the peritoneum. So intraperitoneal bladder injury or dome injury is more severe than the extraperitoneal one. So extraperitoneal one, you just see urine rather accumulating in the retropubic space. That is all, right? And they are going to have the pain, the suprapubic pain, the hematuria, the difficulty voiding and the likes. Just give them the Foley's catheter, they'll be fine. So for urethral injury, you categorize these occur in males, right? You categorize into anterior or posterior. For the posterior, so we have to go back to our diagram. So this is the posterior part of the urethra. So from somewhere here downwards here. Then from here, downwards, this is a penile urethra, this is a bulbar urethra here. So the bulbar to the penile is the anterior, while from the membranous to like the prostatic, that is the posterior. So individuals with the posterior urethral injury usually have that following a pelvic injury. So if they have a pelvic injury, they have a pelvic fracture. That fracture can easily, transmit a pressure which tears off that posterior urethra, usually at the membranous, the bulbomembranous junction, right? So somewhere here, the bulbomembranous junction. So that's the weakest part. So that area is going to be torn when an individual has a pelvic fracture, and we are going to have extravasation of urine into the retropubic space around here. So it's going to cause elevation of the prostate and the bladder. So you can see the urine filling up the retropubic space, elevating the prostate and the bladder. So if you do your DRE to feel for the prostate, you will notice that the prostate is going to be high riding. It's going to be elevated, right? So high riding prostate is somebody with pelvic injury should also raise our suspicion for urethral injury, particularly the anterior urethral, the posterior urethral injury. The posterior, please. Sorry about that. The posterior urethral injury, due to tear at the bulbo membranous junction. So, person is going to present with blood at the urethral meatus. They can have blood at the urethral meatus. They can have difficulty voiding. They can have hematuria. Most of the time, it might not be gross hematuria, but you can have hematuria. You can have blood at the meatus. They can have difficulty voiding, right? And of course, by the time you do your DRE, you can feel for the high riding prostate. So think about a posterior urethral injury. But for anterior, which involves the penile urethra or the bulbar urethra. So this one usually occurs following like maybe penetrating injury to the urethra, like maybe there's a blunt trauma to the urethra, like a kick, or maybe the person fell astride, like the person fell on maybe the bicycle handlebar with the perineum falling on the bicycle, or horse riding. The person just fell on like the perineum of the person fell on an object. That's like a straddle injury. So that can cause a tear, or a damage to the anterior urethral component. So particularly the penile urethra. So the penile urethra can be torn, and you can have bleeding into the scrotum. So they can immediately, have bleeding into the scrotum, causing scrotal hematoma. Sometimes you can have rupture of the bulk fascia, and there's leakage of urine into the perineal space. So but you are not going to find the high riding prostate. So most of the time, the question stem is going to tell us about the high riding prostate, and we should think about the posterior urethral injury. But if you have scrotal hematoma, think about anterior urethral injury. So most of the time, um, if a patient has urethral injury, you don't want to pass um, a Foley's catheter, right? You must, because if you pass a Foley's catheter, you might further exacerbate that injury. So you must do a retrograde uretrography. So you do a retrograde uretrography to evaluate for the injury, right? So before you even consider any catheter placement, you have to do your retrograde uretrography to look at, the injury to the urethra, and these are the particular features that you can see. Blood at the meatus, we have said, is high riding prostate, particularly in posterior urethral injury, difficulty in urinating, the pelvic fractures, particularly for the posterior urethral injury, and associated genital or abdominal injury. So the anterior urethra is defined as the penile and the bulbar urethra. So those are the ones in front, right? An injury to the anterior urethra is seen when you have penetrating trauma to the penis, to the penile fractures, or straddle injury. And what you normally do is that you place like a suprapubic catheter from the bladder so that you don't even allow urine to get to the urethra. That's what you usually do, to drain urine from the bladder so that you can rest that urethra and you don't allow urine to get to the urethra. But if the tissue damage is very significant and you want to, move the urethra repair for another day, you can divert the urine from the, proximal to the site of the injury using your ureterostomy. Just make a small incision and connect the tube to it to drain it out, or you can um, insert a suprapubic catheter in the bladder. So either you make a small incision on the urethra just superior to the part of the injury. So if the injury is, let's say that the injury is here, if the injury is here, you can make your ureterostomy somewhere here, and you can drain urine out, preventing the urine from getting to this place, right? Or you can just insert a suprapubic catheter, into the bladder, and you drain urine, not allowing it to flow to the urethra. So that is that. And till you are capable enough to do the surgery, that is for the anterior. But for the posterior urethra, so you just manage them by putting the urinary what's it called, the suprapubic catheters. So particularly if it's partial. So if the tear is partial for posterior, just put in your suprapubic catheter and rest that urethra. Is going to heal by itself. But if there's a complete injury to the posterior, put in your suprapubic tube first, then do your surgical repair later. So that is the summary. So the summary is that posterior urethra, you are talking about posterior urethral injury, you are talking about injury to the membranous part, like the bulbomembranous junction, right? The patient is going to have a high riding prostate, blood at the meatus, difficulty voiding. And what you do is that you look at it by doing your retrograde uretrogram. So after you have done your retrograde uretrogram, you have seen the site of the injury. If it and the extent, if it's partial or complete. So if it's partial, just put your suprapubic catheter in the bladder and prevent urine from getting to that side. It's going to heal. If it's complete, put your suprapubic catheter and do your surgical repair later. But if it's anterior, what you are going to see is that there's going to be difficulty voiding. There's going to be um, blood at the tip of the meatus. There's going to be scrotal hematoma, right? There could be urine at the perineal space due to tear of the bulk fascia. And what you are going to do is just to put in your what? Your suprapubic catheter, right? To divert urine from getting to that site. And sometimes you might need a period of long diversion, particularly if the extent of injury is very significant, or you are planning the repair for a later time. So you have to do a diversion for a longer time, but by doing, maybe you make um, a ureterostomy proximal to the site of injury, and you divert the urine for a while before you now do your surgical repair if there's a need, right? So that's the way it works. So the rectal and the vaginal injuries can also happen. They are part of the comorbid injury or the comorbid, or like the co-structure that can be injured, right? The rectum, bleeding into the rectum, nerve injury, or the vagina. So sometimes if there are some anatomic destruction of this site, the rectum, the vagina, you might need to do a reconstruction, right? So that's the end of the multi systems.